Hello, everyone. Welcome. Thank you so much for joining us this evening. I want to thank you for joining. My name is Stacy Golub. I'm the Senior Medical Science Liaison with Hologic. I'm joined tonight by my colleague, James Kelvin, Dr. James Kelvin, also a Senior Medical Science Liaison with Hologic. We are going to have tonight's webinar about unlocking new insights about breast cancer index BCI test. Dr. Kelvin, please begin.
Thank you, Stacy, and good evening, everyone. My name is James, and tonight I will be your guide as we review new disclosures fresh on the wake of SABCS. Now, before we begin, a few housekeeping items. Given that we have just the hour together, should you find yourself having questions as we progress through this presentation, then we would ask that you please submit those questions via the Q&A function at the bottom of your screen. Time permitting, we will address these questions during the Q&A at the end. And should you find yourself wanting for more details, given the broad sweep of data that we'll be covering tonight, then we will include an email at the end of this presentation so that you might ask further questions or request original source materials from our team. Tonight, we will be covering three major topics. First, we will be covering new data supporting the breast cancer index test's role for extended endocrine therapy decisions. Second, we will be talking to recent publications and announcements from SABCS that explore the ongoing challenges in determining optimal endocrine treatment duration for patients with hormone receptor positive early stage breast cancer. And finally, we will present a preview of new data supporting the expanded utility of the breast cancer index test, potentially broadening support for personalized approaches early in a patient's journey. For details, stay tuned to our section at the end. And with that, let's begin with the breast cancer index test itself, which remains the leading test for guiding extended endocrine treatment decisions in the late setting. Now, as we proceed through this presentation, we'll need to establish a common vocabulary for what BCI is and what it is capable of doing. So the breast cancer index test answers two distinct questions. Is my patient's tumor biology likely to respond to additional anti-estrogen therapy? This is the predictive component of the test, which is undergirded by a unique gene ratio, the so-called H/I ratio, constituting the ratio between HOXB13 and IL-17BR gene expression. This H/I ratio is also included in the prognostic component of the diagnostic test, and this component assesses an individual's risk for a late distant recurrence. H/I, alongside 9 other genes, they give us a window into mitotic regulation, cellular turnover, and ultimately tumor proliferative capacity, enable us to provide a continuous risk assessment for 10-year distant recurrence for a patient. Now, for those patients who are node positive, we also add tumor size and grade in order to enhance the accuracy of the algorithm. Now, with these two diagnostic components, breast cancer index tests answer these two questions with this simple report. Am I likely to benefit from extended endocrine therapy? You will find a simple yes if the patient is predicted to benefit, or a no on the top of the report. Conversely, what is my specific risk for a late distant recurrence? A patient's residual risk at year 5 and arriving at year 5 distant recurrence free is shown in the bottom left-hand corner of this report. And if she is predicted to benefit, then that extension of endocrine therapy is predicted to reduce her likelihood for distant recurrence by 58 to 67%, reducing in this example 8% to a range of about 2.6 to 3.4%. Now, if the patient is not predicted to benefit, that residual risk remains regardless of further exposure to endocrine therapy. Now, both NCCN and ASCO clinical practice guidelines have recognized this dual prognostic and predictive utility for BCI among recommended genomic tests. So NCCN recognizes BCI as being indicated for hormone receptor positive early stage breast cancer patients who have tumor sizes anywhere from T1 to T3, who are pathologically node negative or positive. ASCO clinical practice guidelines recognize BCI with slightly different language. They recommend that it may be offered to patients who have anywhere from 0 to 3 positive nodes. They also recognize that it could be recommended to patients who have received either tamoxifen, an aromatase inhibitor, or the sequence tamoxifen followed by an AI. They also include additional language specifying that other assays have insufficient evidence to guide decisions about extended endocrine therapy. Now, NCCN approaches this distinction in a slightly different manner by decoupling the predictive and prognostic utility. NCCN recognizes only two tests as being predictive. Oncotype DX, which is predictive for chemotherapy in the adjuvant setting, and the breast cancer index test, which is predictive for extended endocrine therapy benefit in the late setting. NCCN also recognizes all of these genomic tests as being prognostic, but just because they are prognostic does not mean that they are prognostic in the same way. We will come to this in just a moment. And so, Hologic is committed to advancing precision diagnostics in breast cancer care, and for that reason, at SABCS, we announced 11 investigational studies to advance our mission in personalizing care for HR-positive early breast cancer patients. This is the list in full. You'll find 6 disclosures from in-house and 5 from external sources. And tonight, we will highlight several of these abstracts, beginning with those that provide substantive evidence for BCI's current indications. Our first study investigates BCI restratification of risk groups for patients who received the 21 gene assay in the BCI registry study. Now, what is the BCI registry? The registry is a multi-institutional study that investigates BCI as a part of routine clinical testing. In fact, we are currently evaluating long-term clinical outcomes, quality of life, and medication adherence for our patients, following upon our decision impact analyses as well. Currently, we have over 3,000 patients in our registry. So why conduct this head-to-head analysis in the first place? Well, Oncotype DX and BCI are standard genomic tools to guide early and late treatment interventions. And considering that hormone receptor positive early breast cancer patients face a long trajectory over which they might experience a distant recurrence, it's crucial that we can accurately assess risk. Now, the Trans-ACE-TAC study from 2013 actually demonstrated that Oncotype DX could not prognosticate accurately in the late setting. And alluding to the guidelines, once again, ASCO listed Oncotype DX being among those genomic assays that have insufficient evidence to help guide this EET decision. So, given the importance and frequent use of Oncotype in the early setting, and given that previous analyses have actually consistently shown that BCI can restratify prognostic and predictive calls from Oncotype recurrence score groups, we sought to further investigate this relationship with the full registry of cohort. Now, from this cohort, we identified 1,238 patients who had an Oncotype score. You can find the breakdown in this table right here. The vast majority of these patients being over age 50, the 99 of these patients being less than or equal to age 50. Now, after applying BCI to these patients, the results show that because BCI can consistently restratify recurrence score categories, BCI and Oncotype overall have low concordance in their predictions. In fact, those percentages that are encircled in the lavender and cyan boxes show this discordance where predictions go in the opposite direction. In the lavender, for example, you will find those patients who were predicted by Oncotype to benefit to not benefit from chemotherapy, but by BCI are predicted to benefit from the extension of endocrine therapy. This constitutes 16% of those patients who are under age 50 and 29% who are over 50. Conversely, for those patients who were predicted to benefit from chemotherapy, BCI identified a number of patients who would not benefit from the extension of endocrine therapy, 76% under age 50 and 39% over age 50. So, if we had assumed that chemotherapy and the EET decision were correlated, and if we were to have substituted oncotype for BCI, then focusing just on these postmenopausal patients, or these patients who are over age 50 right here, then a significant fraction of these patients would have been undertreated, 29%, or overtreated, 39%, for extension of endocrine therapy. And all of this highlights that we should be using the appropriate test for the validated clinical purpose. And when it comes to predicting benefit from extended endocrine therapy, BCI is uniquely suited to guide that decision. And much as it is suited for the prognostication of 10-year distant recurrence risk, as we find in this next study, in which we explore BCI's prognostic performance in HR-positive, HER2-positive early breast cancer patients who are treated with trastuzumab anti-HER2 therapy from the NCCTG N9831 trial. Now, as we know, patients who are HER2-positive compose about 10% of HR-positive early breast cancer cases, and while BCI validation studies, prognostic and predictive, included anywhere from 5 to 13% of HER2-positive representation, the subgroup is currently not covered by Medicare local coverage determination. So for this reason, we are working to understand BCI's prognostic utility in this critical subgroup. Now, in this translational analysis of the N9831 study, we evaluated BCI prognostic utility by looking at its performance for distant recurrence-free interval in 447 patients, all of whom had resected stage 1 to stage 3 HER2-positive disease. It should be noted that 85% of these patients were N1 patients, node-positive patients, and treated with chemo concurrently or sequentially with trastuzumab with a median follow-up time of 12.7 years. Now, what we found is that when we pool together the node-negative and node-positive patients, we actually find significant stratification between low and high-risk patients with a hazard ratio of 4.50, p-value 0.038. In fact, by multivariable analysis, when we adjust for age and treatment and nodal status, BCI remains a significant prognostic factor with a hazard ratio of 7.54. So overall, this data shows that BCI may provide a 10-year prognostic utility for HER2-positive patients who are taking anti-HER2 therapies. But we should note that due to the comparatively low representation of node-negative patients, constituting 15% of this cohort, and the relatively low distant recurrence rate in the late setting, we are exploring further optimization of the cut point and seeking validation in other cohorts. Now, another clinical subgroup in whom we are exploring BCI's utility are those patients who carry germline pathogenic variants, namely in BRCA1, BRCA2, and CHEK2 genes. Now, despite the fact that patients who carry these germline pathogenic variants, BRCA1, BRCA2, and CHEK2, despite the fact that they display unique clinical pathologic features compared to sporadic cases or those breast tumors that are without a genetic predisposition, the optimal endocrine therapy strategy for these patients has yet to be clearly established. And so we sought to understand patterns of recurrence risk and endocrine response likelihoods in these populations using BCI. So in partnership with the Mayo Clinic, we compared BCI results among 122 HER2-negative early breast cancer patients with germline pathogenic variants, and we compared their results to patients from the BCI registry, 2,563 of them. Now, you'll find the breakdown of those patients who carry pathogenic variants right here. If you add up the numbers, this actually equates to 123 because one patient had two mutational variants in BRCA2 and CHEK2. And here are our findings. When using Fisher's exact test, we compared the distributions in BCI categories for risk of recurrence and likelihood to benefit from endocrine therapy, which overall reveals distinct patterns between those patients from the BCI registry and those patients who have germline pathogenic variants. Way to look at this is for the red and the yellow bars, we are looking at those patients who have a high prognostic risk. In blue and green, those patients who have a low prognostic risk. And if we were to skip from the red to the blue bars, we find those patients who are predicted to benefit. Conversely, yellow to green, those patients who are predicted not to benefit from EET. And by using Fisher's exact test and comparing sporadic cases from the registry to those patients with germline pathogenic variants, we find that the distribution among these categories is significantly different. In fact, when we break this down based on the pathogenic variant, either in BRCA1, BRCA2, or CHEK2, we find that the significance maintains itself for BRCA1 or BRCA2 carriers, but not CHEK2. Secondly, when we look at prognostic risk among those patients with pathogenic variants, we find that there's an enrichment for the red and yellow bars, high risk in BRCA1 and BRCA2 compared to the BCI registry. We also find with the red bars a high likelihood to benefit, constituting about 2/3 of BRCA1 patients, a little over 35% for BRCA2 carriers compared to the 25% from the BCI registry. So these findings are exciting, but they do warrant further investigation. Ultimately, they may inform personalized endocrine therapy strategies for these patients. Now, just as we are investigating BCI utility in HR-positive subpopulations that are distinguished by molecular pathology, HER2-positive patients, or carriers of germline pathogenic variants, we are equally interested in understanding BCI's utility across diverse demographics. In a recent published study, in partnership with Dr. Fukui, we sought to understand whether BCI detects differences in prognostic or predictive calls between women of different racial origin. So, we conducted a retrospective chart review of 159 women from Hawaii with early stage hormone receptor positive breast cancer. And these women self-identified as being either Caucasian, Filipino, Japanese, Native Hawaiian, other Asian Pacific Islander, or other. You can find a wide range of clinical features right here. We also tested BCI and looked at prognostic categories defined as low, mid, or high risk for distant recurrence. We also evaluated likelihoods to benefit from EET. Now, here's how we read this. In the blue bars, we will find those patients who are predicted not to benefit from EET. In the orange bars, those who are predicted to benefit from EET. And after conducting multivariable logistic regression, no major racial differences were found for EET benefit prediction, suggesting that BCI's predictive value is consistent across racially diverse populations. Now, when we dive into this a bit further, we actually find that Japanese and other Asian Pacific Islander patients have significantly lower odds of having a high risk prognosis, which suggests that there might be potential variations in tumor biology or other genetic or environmental factors that feed into these differences. Now, there are some limitations to the study, not least of which is having 159 women, also not having representation from other racial groups, and an absence of survival data. And all of this underscores the need for further research to adjust for known risk factors and further clarify BCI's interaction with racial and ethnic populations. Now, just as we are working to understand BCI's utility across diverse populations, so are we working to equalize access. for eligible patients and to implement measures that might facilitate guideline concordant care. And so, in partnership with the City of Hope, we tracked BCI usage across community centers based on pivotal events, including a timeline pre and post guideline inclusion, as well as following integration with an Epic EMR system. This study was conducted across 21 community centers and at the central location for City of Hope in Duarte, Los Angeles. And what we found was that following BCI's inclusion in the NCCN guidelines, nearly 4 times more patients received testing compared to the era preceding, which demonstrates a broad compliance with NCCN guidelines and testing in eligible patients. Now, a notable increase was also observed for BCI test orders following Epic EMR integration, and ensuring that we can provide guideline concordant care for all subpopulations of HR-positive early breast cancer. This necessitates that we also address persistent challenges in therapeutic management. And so we are now going to look at 2 publications that address challenges in therapeutic management that dovetail into the major themes announced at SABCS for hormone receptor positive early breast cancer patients. We will begin with this study from Kaiser Permanente, which highlights 2 challenges that undermine the therapeutic effect of EET, namely adherence and early discontinuation. This retrospective study of a large population, which included 13,675 women with stage 1 to stage 3 ER-positive breast cancer, this was investigating the rates of adherence and continuation over a 10-year span for those patients who had been prescribed extended adjuvant endocrine therapy. And here's what we found. With adherence defined as a medication possession ratio over 80%, you'll find adherence rates on the left-hand side. And you'll find that among those women who had initiated AET at year 1, we have 79% adherence, which gradually declines to 60% by year 5. There is a dramatic drop between years 5 and 6 to just north of 20%, which declines all the way still to 10% by the 10th year. Looking at discontinuation rates, we find that 5% of patients actually discontinue adjuvant endocrine therapy within the first 6 months. We have a 52% continuation rate at year 5, which steeply drops, similar to the adherence rate, to 20% at year 6, with only 4.5% of women continuing endocrine therapy in year 10. So, what can we take away from these findings? There's a dramatic decline, both in adherence and continuation, which ultimately impacts extended endocrine therapy, with the inflection point at year 6. Now, this inflection point represents a significant missed opportunity to improve long-term outcomes in hormone receptor-positive breast cancer patients, with year 5 as a pivotal window in which we can intervene. Now, genomic tests that individualize risk and predict benefit might improve rates to adherence. In fact, from our registry study, we surveyed patients who were predicted to benefit from extended endocrine therapy, and among those women, they reported 82% of them as being more likely to be compliant following their BCI result. This further highlights the fact that personalized results may help patients gain commitment to their treatment plan, which might thereby optimize the intended effect of the prescribed regimen. And speaking to the benefits that patients might gain from a full 10 years of therapy, let's discuss this meta-analysis from the Early Breast Cancer Trialists Collaborative Group, in which the authors asked, for how many folks, or for how long, should we extend endocrine therapy? And should everyone receive 10 years of endocrine therapy? In this study, EBC-TCG pulled from 12 randomized clinical trials constituting over 22,000 postmenopausal patients who had a median follow-up of 8 years to evaluate the effects of 5 additional years of aromatase inhibition versus control. They approached this question in 2 ways: by looking at overall recurrence of invasive disease, which they define as local, distant, and new contralateral events, and distant recurrence, looking at outcomes 15 years after diagnosis or 10 years after treatment divergence. Now, in these 2 graphs, you are finding patients who had 5 years of previous aromatase inhibition, who are allocated either to the control arm, as you see in these blue circles on these top survival curves, or to 5 additional years of aromatase inhibitor treatment in these square dots down here. Now, during the decade after treatment divergence with a median follow-up of 8.1 years, the risks of recurrence between the control and the AIT group were 15.2% and 11.6%, with an event rate ratio of 0.71. This means that there's a 29% lower risk of recurrence for those patients who continued on for the full 10 years, with an absolute difference of 3.6%. We find similar results when we measure distant recurrence. In fact, the event rate ratio between these 2 arms is 0.73, constituting a 27% lower risk of distant recurrence, with a 2.0% absolute difference. It should also be noted that for those patients who continued on for the full 10 years of therapy, with 5 additional being aromatase inhibition, that bone fractures significantly hiked up when comparing control to the 5 years of AIT, namely from 3.4% to 4.6% of patients, with a hazard ratio of 1.35. Last note, these are unselected patient populations, so we are seeing the effects by sheer randomization. Might we see amplified effects by biomarker-based selection? By contrast, the breast cancer index test found through 3 studies that were included in this meta-analysis, namely MA17, IDEAL, and B42, a consistent relative risk reduction of 58% and greater for those patients predicted to benefit from AIT continuation, as opposed to the 29% of overall recurrences that we found from the meta-analysis. In fact, if we were to focus only on those patients who had begun on an aromatase inhibitor or had made the class switch, as we see in IDEAL, that relative risk reduction here jumps up to 66%, and the absolute benefit noted is 11.8%. Compare this to the 3.6% reduction we find in the meta-analysis. Now, just as important, BCI also demonstrated reproducible utility in identifying those patients who do not benefit from EET, constituting anywhere from 49 to 62% of the patients that we observed in our studies. So, with amplified relative risk reduction and greater absolute benefit based on predictive stratification of patient responses, BCI demonstrates here the importance of using biomarker-based selection so that we might individualize treatment decisions and maximize benefit for those patients who are likely to respond, or avoid unnecessary side effects for those patients not likely to respond. Now, the recent highlights from SABCS. The recent highlights demonstrate that the precision guidance of therapeutic selection remains a key focus in our field. And based on the SABCS announcements, this is because of distant recurrences. It's because of preventing distant recurrences, both in the early and late settings, particularly for higher risk patients. This is of paramount importance to drive better outcomes. And a second takeaway that we got was that evaluating late recurrences remains a risk, evaluating the risk of late recurrences remains a challenge, which underscores the need to continue individualizing treatment for patients. And finally, SABCS highlighted unique complexities and managing premenopausal breast cancer care, which highlights the need also for more personalized approaches in this population. So at SABCS 2025, several studies unveiled new tools that are assessing late recurrence risk. These included AI models like the multimodal model presented by Dr. Joseph Sperano, integrating imaging, clinical, and molecular features, or the so-called M3T, multitask model by Dr. Terry Maminis, or the sensitivity to endocrine therapy ERPR index, also presented by Dr. Terry Maminis of Gene Expression Assay, and of course, the late-breaking data on oral SERDs introduced into the adjuvant setting. Now, these studies collectively highlight the urgency in early breast cancer care to accurately evaluate late recurrence risk and to identify the most effective treatment interventions. And while this data unveils the potential of different tools to inform late-setting prognosis and treatment, the breast cancer index test remains the leading predictive tool to guide extended endocrine therapy decisions. This is based on exclusive guideline recognition by both NCCN and ASCO clinical practice guidelines for BCI's ability to predict EET benefit among HR-positive early breast cancer patients. Now, this recognition is based on being the most extensively validated test in this space, which includes 5 translational studies and over 4,700 patients. Building upon this validation, we have also shown clinical impact with BCI in our registry study, with providers altering treatment plans in 40% of patient cases following a BCI result. Coming back to SABCS, and now speaking to premenopausal patients, other sessions than the general sessions actually focused on clinical need for subpopulations like premenopausal patients. We are now going to cover 2 of these sessions, one by Dr. Virginia Borges and another by Dr. Yara Abdu. We're going to describe the unique challenges that are faced by young breast cancer patients. Now, when it comes to the treatment of young breast cancer patients, there are multiple considerations to factor into their care. First, young breast cancer patients are 35 years or younger, and these patients have a poor prognosis and a heightened risk for psychological distress. Now, of course, the goal is always to improve survival outcomes, but balanced care requires considering numerous other factors, not just aggressive disease biology, but also mental health support and, pertinently, concerns over fertility. In other words, the treatment of young breast cancer patients is complex and requires multidisciplinary considerations in addition to therapeutic intervention. Now, one of the key challenges that we face in young breast cancer patients is non-adherence to therapy. In an IBCSG analysis of the SOFT and TEXT trials, they found that nearly 1 in 5 young women discontinued protocol-assigned therapy early. In fact, those patients who were under 35 years old showed a greater cumulative cessation of oral endocrine agents and ovarian function suppression compared to those patients who were older. An earlier study by Hirschman et al. At Kaiser Permanente showed that patient age significantly associates with early discontinuation and non-adherence. Now, among 8,769 patients with stage 1 to 3 HR-positive breast cancer, less than half of the patients finished endocrine therapy at the full duration at the optimal treatment schedule. And so, when we stratify these patients by age, we actually find that for those patients who are under 40 years old, they have a 50%, they are 50% more likely to discontinue therapy early relative to other age groups and 40% more likely to be non-adherent. So this begs the question, why are young breast cancer patients less adherent than other age groups? Well, there are numerous drivers, including disadvantaged socioeconomic conditions, a fear of or experience from side effects, even being less informed about endocrine therapy. But the salient driver that consistently stands out across studies are concerns over fertility. The prime message being that we need to personalize approaches for young breast cancer patients based on the unique challenges that they face. We recognize this need to manage risk while preserving the quality of life for these women. And to this end, building on the role of BCI as an established test for guiding EET decisions in a late setting, we are very excited to share new data presented at SABCS that supports the expanded utility of the test to help personalize treatment approaches for premenopausal women. Here, we are going to review data that evaluates the ability of BCI to identify a group of premenopausal patients who are at minimal risk of distant recurrence. In this study, we set out to validate a new BCI prognostic cut point that can identify premenopausal node-negative patients who are at a minimal risk of distant recurrence. This is defined as a risk of less than 5% over a 10-year time span. Now, BCI is currently indicated for EET decisions, but a new prognostic cut point, this one, was identified and validated to classify postmenopausal node-negative patients who also had a minimal risk of distant recurrence with or without endocrine therapy. And so in this study, we evaluated the performance of this new BCI prognostic cut point in premenopausal patients, hormone receptor positive and node negative, from the SOFT and TEXT trials. You will find that breakdown of patients in this table right here, with 1,110 of these patients coming from the SOFT trial, 915 from TEXT. Now, we should also mention that there were 3 treatment arms in the SOFT trial, tamoxifen only, or the addition of ovarian function suppression on top of tamoxifen or exemestane endocrine therapy. TEXT was similar without the tamoxifen control arm. Our primary endpoint here was distant recurrence-free interval with median follow-up time of 12 or 13 years. In the SOFT cohort, we are looking at patients who are less than 35 years old or older than 50, all premenopausal, around 75% with T1 size tumors, a little over 70% of patients who have moderate to poor grade tumors, and about 37.3% of these patients were allocated chemotherapy. Among these 383 patients, BCI identified 4 prognostic categories. In the red, green, and black, you will find those patients who are at high, intermediate, and low risk. And in this shaded black line, you will find those patients who are at minimal risk. This constitutes 16.2% of patients who have a 10-year distant recurrence risk of 3.5%. Does this look any different for those patients who also take ovarian function suppression? With similar clinical characteristics and allocation to chemotherapy, we are now looking at 727 patients. Once again, we find differential stratification between high, intermediate, and low-risk groups. But in this dotted black line, we find 18.6% of patients classified as minimal risk, ultimately landing at a 1.7% risk for 10-year distant recurrence. Do these results carry through in TEXT? With similar clinical characteristics, albeit with a higher proportion of patients with T2 plus size tumors, more with moderate to poor grade tumors, and slightly higher allocation to chemotherapy, we once again find stratification between high, intermediate, and low risk groups. And for those patients classified as minimal risk, 19.6% of patients who are at a 2% risk for 10-year distant recurrence. And so, when we pull back and look across all four analyses, including in this upper left-hand side, all soft patients, we see that BCI consistently identifies a group of premenopausal patients, anywhere between 1 in 6 and 1 in 5 among these cohorts, who are at minimal risk, meaning that their risk for distant recurrence over a 10-year time span remains beneath 5%. And thus, we should ask, for these patients at minimal risk, might adjuvant tamoxifen alone be adequate endocrine therapy? Might these patients forego unnecessary side effects and quality of life challenges that are attendant with ovarian function suppression? Taken together, this study confirms the prognostic ability of BCI to reclassify a subset of premenopausal patients, hormone receptor positive, node negative, who are at minimal risk for 10-year distant recurrence, breaching no greater than 5%. Now, a minimal risk classification personalizes prognosis for premenopausal patients that they might reconsider the inclusion of OFS and potentially forego unnecessary side effects or challenges to their quality of life. Or, if classified otherwise, these women might gain commitment to treatment plan adherence. And thus, these data build upon BCI's utility as the leading genomic assay for EET decisions and support its expanded utility to personalize treatment approaches for premenopausal patients. Now, we are very excited about this new application of the test, and we will continue to share with you more updates as we approach commercial availability over the coming months. We've now reached the end of our presentation. So when we take everything in total, what have we seen today? First, the breast cancer index test remains the leading test for extended endocrine therapy decision-making. This is based off of exclusive guideline recognition, predicated on extensive validation, and with proven clinical impact. Second, endocrine therapy adherence remains a challenge, with a significant percentage of women discontinuing treatment prior to the 5-year mark. And new data supporting expanded applications of the breast cancer index test will support earlier, personalized decisions to help women avoid unnecessary side effects or gain commitment to their treatment plan from the start. Stay tuned. It's coming soon. And with that, we've reached the end of our presentation. The floor is now yours. This is your opportunity to ask us questions, and I thank you for your attention.
Thank you so much, Dr. Kelvin, for that excellent and very thorough presentation. Just a few housekeeping items for anybody who did not hear at the beginning of the webinar. Any questions that you have, please submit them in the Q&A box below. And we've had quite a number of questions being asked in the Q&A box, so I think we should get started if that's okay with you, Dr. Kelvin.
Wonderful.
Great. The first question that came through is why not consider 7.5 years? I'm guessing that's instead of the 10 years, a 7.5-year
Sure.
endocrine therapy.
Sure. No, that's a fantastic question. We know SALSA and IDEAL trials actually tested this very question, both of which were included in the meta-analysis that we reviewed. So EBCTCG actually looked at this question. If I recall correctly, if you look at figures 3 and the forest plot in figure 4, you'll actually find that they are modeling the decrease in event rate ratios for total recurrences consistent with the increase in aromatase inhibitors. So that's to say that if you add 2 to 3 years of therapy, your rate ratio is lower compared to no years or 0 years of an extended treatment. Whereas if you increase with a full 5 years, there's a larger difference between those years. Now, In a separate analysis, they actually asked, what's the difference in the effect size between those patients who received 2 to 3 years versus a full 5? And they actually find that there's a greater reduction in overall recurrences that appears around 2 to 4 years after treatment divergence for those patients who have 5 full years rather than 2 to 3. They also note that it's more durable of an effect. So effectively, they're saying it's 10 years or 5 in this case.
It's great. Moving right along to our second question, what are your thoughts on CTS5 informing EET decisions? I'm guessing that's the CTS5 online calculator, I believe.
Correct. Yeah, so CTS5 is a prognostic tool, right? It is predicated on clinical pathologic features in order to make a prognostic assessment of patients' risk of recurrence. There's a clear distinction in diagnostics between prognostic and predictive utility. If something is prognostic, it means that it gives you a risk. If something is predictive, it means that it gives you an indication of the tumor's response biology. CTS5, other diagnostic tools are not built for that purpose. BCI is the only one that is validated and recognized for doing so in the extended endocrine therapy space.
That's great. That's very informative. Thank you. The next question, what data exists to support BCI and node positive patients? I think this is a really important question.
Great. So this is actually a robust piece of our validation data. I had mentioned that we had 4,700 plus patients in our validation studies. 2,500 of those patients are actually node positive, right? And that's in our predictive validation study. If we just look at the TransAtom study, this was 789 patients, all of whom were node positive. And I should also mention that when Atom was actually going on, they did not note those patients who were N1, N2, N3. So we just have node positivity. There might be some N2 and N3 patients included in our analysis. What we find is that after we apply BCI as a predictive tool, that it identifies a 67% relative risk reduction for those patients who continue with another 5 years of tamoxifen versus stopping at 5 years, at least for that population that's predicted to benefit. This is also a 9.7% absolute benefit that we observed. But I think the converse, in fact, is just as important. When you look at that population that is predicted not to benefit, we actually find that there's a negative 1.2% benefit. Let's say it's intimating harm, but when you crunch the numbers, it's not significant. So we can actually individualize treatment quite well for node positive patients. And I will also mention that we have extensive prognostic validation for node positive patients, 400 plus patients in a node positive only cohort looking at our prognostic utility. And this was validated further in the tamoxifen exemestane adjuvant multinational, the team trial with over 1,600 node positive patients.
That's great. Thank you, Dr. Kelvin, so much for answering that as well. Moving right along, there are a number of questions, so I'm trying to make sure that we get to a little bit of everybody's. I think this is a great question. At what point in my patient's treatment can I order a BCI? Is year 6 too late?
No, year 6 is not too late. Year 9.9 is also not too late as far as BCI validation is concerned. So you can actually order BCI at any time during a patient's treatment journey. We do recommend year 5 because the results are validated for those patients who reach that time, who are distant recurrence free by year 5. And the prediction of that test is based on whether or not you should continue for another 5 years of endocrine suppression or not.
That's great. Thank you. I think this is another very topical question considering that we just had SABCS. What is the role of BCI testing in light of the uptake of CDK4/6 inhibitors in the adjuvant setting?
Wonderful question. So I will say outright at this moment, we have not disclosed any data showing BCI's interaction with CDK4/6 inhibitors, but we are always looking to expand our utility with this complex therapeutic domain.
Yes, makes a lot of sense, but thank you for answering that. So, let's see, moving along. This is also fairly topical and a big discussion point, I think, at SABCS as well. And the AI tools you mentioned earlier in the presentation, were any predictive of endocrine therapy?
Good question. So, the multimodal multitask, the M3T model that was presented by Dr. Terry Mamonis, was developed in the B42 trial and then validated in Taylor X. When they were developing this model, they actually indicated that they looked at a potential treatment interaction for extended letrozole therapy or placebo based on the study design from B42. In effect, they actually found that there was no significant treatment interaction by risk category. So in effect, that AI model was not predictive for extended endocrine therapy benefit.
Fantastic. Right, continuing to move along. Also a big discussion point at SABCS. I can tell a lot of people either attended or spoke with their colleagues who were able to attend, and I know a lot of these are very topical. Is there
Sure.
BCI data for patients being prescribed SERDs? And
Ah,
maybe describing what SERDs are to the audience, who anybody who was not able to attend SABCS. In brief, we are wrapping up at the end of the hour, and that's another note to anybody who is still attending. If there are any outstanding questions that are not able to get to in the next 7 minutes, please, there's an email listed here that you can submit any questions to, and we can respond to you directly. Please take the floor, Dr. Kelvin.
sure, sure. Yeah, so this was the talk of the town. Dr. Aditya Bardia, I believe it was in the ninth talk, the first general session, was speaking to the data of giredestrant versus standard of care endocrine therapy in the adjuvant setting. So they unveiled data at the 3-year time point that demonstrated that giredestrant, when compared to standard of care ET, so this is tamoxifen or aromatase inhibitors, actually demonstrated a roughly 30% relative risk reduction in invasive disease-free survival. They also showed some similar results for overall survival. Now, this is quite exciting. It's the first improvement, according to Dr. Bardia, that we've seen in the adjuvant setting for a monotherapy. But there are some things to take into consideration here. Number one, this data is very new. So we do not yet have any data looking at BCI and adjuvant oral SERDs. The second is that, of course, this data being at year 3, we do anticipate or hope for, of course, that this data is durable, that the results bear themselves out, let's say by year 7. Right now, they are on track to show the same sort of benefit that we saw with CDK4/6 inhibitors. And I believe that there's optimism that these will be approved at some point in the future. With that said, the patients that they enrolled in this trial, although they were stage 1 to 3 anatomic tumors, we're actually looking at high-risk patients. The inclusion criteria named node-positive patients, Ki-67 greater than or equal to 20%, and also look for patients who had grade 3 tumors, right? So we did disproportionately select for those patients who would have quite a few events, both in the adjuvant setting and likely in the late setting, based off of their clinical risk. The last thing that I'll say is that as far as this might influence or impact the extended endocrine therapy setting, I don't think that anyone knows. And in order for us to understand that, we'll need at least another 10 to 15 years before we have probably the first data set. And so this is still an open question. It's certainly exciting that we have potentially a new entrant or class of therapies in the adjuvant setting. And as always, we're always looking to expand the utility of our test and understand it in different therapeutic contexts.
That was an excellent answer, Dr. Kelvin. Thank you so much. It is so topical with this coming up at SABCS and how it relates to BCI. So I think these are really wonderful questions and one that we're all very excited, I think, to get the answer eventually. I know we only have about 3 minutes left, so I'm going to just ask two more questions. Anybody who has outstanding questions, please submit them to the email listed on the slide here. We'd love to have your medical science liaison respond to you directly and make sure that any outstanding questions are answered. So, in the last couple of minutes here, is BCI indicated for lobular carcinomas?
Yes, in a word, yes. We actually have a paper dedicated to understanding the prognostic utility of BCI and ILC. We actually show significant stratification for 10-year distant recurrence risk for low and high risk populations in ILC in that paper. And we also have lobular carcinoma patients included across our predictive validation studies. If we only look at the ideal study, which by the overall population, once again, we found a 9.8% absolute benefit, 58% relative risk reduction. We included 16% of those patients who had ILC histology. I will also mention that patients of mixed histology were also included in that cohort.
Great. And just one more quick question. Any data for testing for patients with 4 positive nodes?
Excellent question. So we are not indicated for N2 or N3 tumors, but we do have data. In fact, from the ideal trial that I mentioned, we did include some patients who are N2 and N3, and it's likely that we included those patients as well in TransAtom, although the annotations are not there, since at the time that wasn't the practice with that trial. So it's
That's
likely
great.
that these patients are a part of the benefit that we find in our predicted groups.
Thank you so much. Thank you so much, Dr. Kelvin, for joining us for this excellent presentation. There was a lot of wonderful feedback in the Q&A already about the presentation, and I think these questions are very thought-provoking and showing the engagement as well. Thank you, everyone who is still attending at this point. And if you haven't dropped off yet, thank you so much for your attendance and all of your questions that have come through. Again, if we were not able to get to your questions this evening, please submit them to the email shown on the slide. Your medical science liaison will be reaching out to you and hopefully be able to answer any questions that you have. Again, thank you to all of you, and thank you again, Dr. Kelvin, for this presentation.
Thank you. Have a good evening, everyone.